Good morning, everyone. As a part of every week Thursday's academic meet, today we are going to discuss 4 interesting cases which we came across during last month. And I welcome all the participants, especially Dr. Mihir Thakur. He's a beloved friend from US, is a pediatric orthopedic surgeon. Mihir has a great work in pediatric tumors, and as a couple of cases today are soft tissue tumor, we thought that Mihir's presence would be of great help. So welcome, Mihir. Dr. Prasad Dorinani is operating at the moment in Chicago. He might join soon. So I welcome all the experts. I also welcome Dr. Sonali Desai, who is a well-known musculoskeletal radiologist from Ahmedabad, and Dr. Sanjeev Shah, who is a musculoskeletal histopathologist. Sanjeev has been of great help in coming across important clinical histopath diagnosis. Also, we have Dr. Santosh Raivakar, senior plastic surgeon, who is part of our team and who has helped us in a couple of cases, in few cases here. And Dr. Mandeep Shah would eventually join, who has also helped us in these cases. So Gaurav, please, and Thomas Polikaran, Thomas is here. Thomas is my buddy from Sick Kids and is professor at CMC now. Welcome, Thomas. So Gaurav, please start presenting the case, and we'll invite the experts for their comments eventually.
So very good morning to all of you. So let us start with this case. This is a 5-year female child with deformity of right leg since birth. Family is poor, so they didn't consulted much about the deformity. So at around 5 years, she had a fall and got a fracture of both tibia and fibula, which they tried to manage with plaster cast, but it didn't unite it, and was diagnosed as congenital pseudoarthrosis of tibia. She also had some cafe au lait spots, and this was the X-ray with which she presented.
Right. So, so Gaurav, what were your initial thoughts about managing this, and how this pseudoarthrosis is looking different than the routine we see?
Yeah, so in my fellowship with sir, I have learned about cross union, and I was on the same lines, but then I was concerned about negotiating my nail through the canal because there is one more curve above the fracture, and it required some kind of a corrective osteotomy. And I have never seen doing one more, osteotomy in a CPT case, so I was concerned about that.
Besides that, you know, when we had fortune to have Dr. Alvin Crawford visiting us at Ahmedabad during his mission trips, and we had discussed a few cases of CPT. And I remember him advising that when this central segment is extremely sclerotic, it is sometimes it is wise to excise the whole segment. And when you open up, you see this periosteum is kind of diseased throughout the sclerotic segment. So he was of, we had a few surgeries where we failed. And then he suggested that since the outset, you should have done excision of the diseased segment bravely, and then you have to interpose something. So what I see in your case also is a central. Now I'll invite Thomas. Are you with us? Thomas?
Yeah, I'm there.
Thomas, how would you, what would be your plan of management for such case, and what difficulties you foresee with this kind of X-ray?
No, I just joined in late. This is a CPT, no?
This is CPT, 5 years old, recently fractured.
Yeah. So like you said, a meticulous excision of the hematomatous tissue till you get bleeding bone. and then we usually rush rod the thickest rush rod possible and bridge it with a non-lay graft. But,
Yeah.
the excision should be very meticulous till you get bleeding tissue, and all the hematomatous tissue should be excised. Otherwise, recurrence is a possibility.
So Gaurav's concern was valid that there is the procovertum deformity of proximal segment.
Yeah.
So if you put a nail, either antegrade or retrograde, it will need one more osteotomy in the proximal segment, you know.
Yeah. So sometimes we just stop it short of an osteotomy, just bridge that
Anterior cortex.
Anterior cortex thing, and then revise the nail once the union is achieved. So we don't do a double osteotomy in a CPT case at the first instant.
Okay. So Mihir, would you like to give your input? Yes, Mihir.
I think that sounds very reasonable. I think getting it down to healthy bleeding bone oftentimes will end up needing probably about a centimeter and a half worth of bone excision, sometimes up to 2. In this case, the central segment is, as you pointed out, quite sclerotic. But oftentimes you're able to get away with not excising the whole thing, like we were discussing, and you can get a rod down. My question to you guys is, are you using more of the rush rods? Are you using the Indian FD nails? Are you using regular FD nails? What are you using these days?
Yeah, so in earlier on in our practice, I have worked with Dr. Will Cole at Sickies, and he used to use the Williams rod, which is in retrograde nail. So, and when we came here, we saw Dr. Benjamin Joseph. So we have used this retrograde rush rod when the distal fragment is very small. We have tried antegrade rush rods when the distal segments are diaphyseal CPT, you know, but in this, I would like to pass a nail through the transcalcaneum. Recently, after listening to this Dror Pele and our studies from Mumbai colleagues from Wadia, we have switched to using Indian-made FD rods. So yeah, those are the options.
Yeah,
My
I think
preference,
in this case, in this case, I think you have enough of a distal fragment for you to be able to get adequate purchase, and you could probably lock the epiphyseal end distally in the epiphysis with a K-wire. So that tends to hold reasonably well, even though it is an osteopenic segment.
Another thing, Gaurav, I remember from Bill Cole's teaching was, you excise minimum of bone, because whatever you do, the pathology is going to be same. So try to negotiate your nail, make your canal bit bigger, wait for this bleeding bone to come, but just like, you know, do not excise a lot of bone to start with and go gradually, you know. That was the advice. So please show us what you have done, and then we move forward.
Yeah, so I also posted this case in a Pedipods group, and majority of people were of the opinion that we should do osteotomy above the sclerotic segment, which the bone above the sclerotic segment looks normal. And family also wanted that we should correct the deformity also. And so I opted to do this cross union, and I did an osteotomy above the sclerotic segment, and did a thorough excision of the hematomatous tissue, as Dr. Thomas said. It was very different periosteum, very thick periosteum. I removed it circumferentially, and took a lot of iliac crest graft, took a solid cortical squares of the graft also, and onlayed it anterior and posterior, and gave bisphosphonates 1 month before the surgery.
You have placed a fibula graft?
No. It was iliac crest cortex. Iliac crest cortex, as mentioned by Dr. Dror. So took 2 sheets of iliac crest inner side, and took a lot of cancellous graft, placed in between the interosseous space, and 1 sheet anterior, 1 sheet posterior.
And how could you ream the central segment?
It was it was very tough to ream the central segment. I used forearm reamers, and the reamers which were gave with the implant, these are Indian FD rods. So
So
I
it seems
reamed
that you could that part got broken in the front.
there was
The
a slight,
tops.
yeah, there was a
Huh.
slight break, but this is what we are seeing is a graft placed there. So I had some
Okay.
extra graft, so I placed there also.
Okay. That's a brave surgery. But looks pretty well aligned mechanically, both in AP and lateral view.
Yeah,
And there is also there are different views about whether you need to fix fibula or not.
yeah,
Right. And Dr. Anil Agrawal from CNBC says, please explain use of two implants. So what's the use of two implants? I think he's saying the use of FD rod probably. So the purpose is that this thing should telescope with the time. I have doubts that when your the female rod is snug fit like this, we wish it would telescope. Most of the time it leaves the distal fragment when it is very jam in canal. Fine. So let's come to the case. The main issue starts now,
yeah.
Gaurav.
So I was very happy post surgery. I was able to copy book the technique and everything, and closure and everything was good. So I was very happy. But then this was there on the third day. So the skin was looking charred, and I was terrified
Right.
after seeing this
So
image.
let me invite Dr. Santosh Raibakar, sir. Dr. Raibakar, as I mentioned, is a senior plastic surgeon. Sir, are you with us? Let me see. He has muted himself.
Hello.
Yes. So, sir, this is
Hi,
the
morning.
scene. Hi, sir. So this is the picture on the fourth day, Gaurav.
Yeah, on the third day.
Third day of what is this bluish discoloration, Gaurav? It is a mark, the surgical mark, pen mark, or what is it?
No, it is. I mean, this might be a hematoma, and this skin looks all as if it has been burned.
Okay.
Yeah.
Yeah, Dr. Raibakar, sir, what do you think it is and how we should approach it now?
Basically, it looks like as if the central portion is necrotic and all the layers of skin are necrosed, but the surrounding color suggests that it is something like a deep partial thickness burns, and it would definitely heal with dressings. Gaurav, what was the age of the child? You said 5 years?
Right, sir.
Right. Yeah. So the healing is good in pediatric cases. So I think one has to do dressings and see how much the wound contracts.
So what dressing should we use? I mean, what material should we use for dressing?
I routinely use silver sulfadiazine, and I've seen good results with silver sulfadiazine. So that's what we use in burns. And that's how we begin dressings, the burns with silver sulfadiazine.
And sir, what do you think could be the cause of this necrosis?
To think with, I think more of, I don't know, reaming or hematoma underneath, since you have dealt with that bone. And this is, I think, hematoma leading to necrosis of skin.
Yes, Mihir, anything would
I
like
think
to
some
put?
of this is extensive soft tissue dissection around your shortening site and also for the cross union, because you have to go all the way from the tibia to the fibula and you have to raise flaps. And the challenge here is, for the subcutaneous border of the tibia or the subcutaneous surface of the tibia, once you start raising flaps and you want to leave the periosteum intact or excise that periosteum, your flap is going to be quite compromised and quite thin. And then based on how much graft you stuff in there, then you start running into issues with hematoma, tight closure, and skin devitalization. The other thing that, if you truly followed Droer's technique, and he also talks about using BMP, which in itself can cause a tremendous amount of swelling and, fluid build up in the area, which also can compromise skin. We've had that once very early, we picked it up on day one, basically, because instead of having this kind of a construct, I had an intramedullary Steinman pin and a circular X-fix, so the skin was easily visible. But it can cause a pretty intense inflammatory reaction and swelling, and that can compromise your skin flaps. So fortunately, we were able to release our skin suture before we ended up with flap compromise. But this is kind of what it looks like. It looks like a burn. It looks like there's a lot of swelling, a lot of blistering around there.
So one, like Dr. Anil Agrawal also mentioned that sometimes a tight packing of bone graft and aggressive debridement. What I would suggest that your skin incision should be quite generous so that you can retract. And sometimes we have received or retrieved more graft and we want to pack it. So that can be also a problem. Fine. So show us what you have done, Gaurav. Dr. Raibakar sir would like to do the silver sulfur-diazine dressing. Wow.
Yeah.
This looks.
So this is on around the 10th day. So I would like to ask, sir, still we should follow with dressings, or do we need to do something else?
Yeah, I think you have to allow and see whether this wound granulates or not. So I think you have to do dressings only now.
Okay, sir.
So there's an Escher formation in the center, as you can see, the black one.
Yeah.
And we had one thermal burns while doing this SAMI-T transfer in the front. Dr. Raibakar sir would remember that very difficult situation early in my practice.
Yes.
So this gradually with this heals from the side and the gradual debridements, you should not be very aggressive, otherwise at the side of Escher there will be full thickness necrosis and your just bone is lying underneath. So sometimes very aggressive debridement will lead to problem, but they gradually heal. Yeah, go ahead.
Yeah, so I consulted a plastic surgeon here and he suggested that we should do some kind of a flap as the bone is underneath, reconstruction is underneath, but the family was not affording and they said that we'll do dressings. We started silver sulfur-diazine dressings, and progressively this wound healed with dressings only. And this is at the time of plaster removal. We removed the plaster after 3 months because we were waiting for the bone to unite, and this healed with dressings only.
So I have seen that this families, once they have undergone one or couple of major surgeries, they say it's a try with dressing, and in all the 2 or 3 cases which have happened with us, the primarily plastic surgeon would advise that to cut short the duration of treatment and to prevent the secondary infection to set in, you do with a flap. And all the time parents say, let us wait, and this is the end result in all those cases. Although it leaves behind an ugly scar for a pretty long time, but eventually it merges with the surrounding skin. So Dr. Raibakar sir, final verdict on this?
The wound has definitely healed, but I think we have to advise the child not to have trauma over that portion, because the healing is definitely with scar formation. And if we take a biopsy of this scar, then we would not have dermis in it. So it is a papery thin scar, and one has to be very careful if it is on the shin of tibia. So you have to be in the sense she should not have trauma while playing, or she should be very careful.
Yeah.
Okay.
Dr. Anil Agrawal is asking, is there any other alternative to the dressings? Dr. Raibakar.
There are, I mean, the best is, I think, silver sulfadiazine. One can definitely go ahead and do other creams, but the advantage of silver sulfadiazine is that that's the only cream which penetrates HR. That's the only cream available till today. No other cream will go to sub-HR level and kill bacteria. So silver ions, actually, what they do is they, act on the cell membrane of the bacteria, and then that cell membrane coagulation occurs, and ultimately the DNA replication stops. So I think the choice should be of any cream containing silver ions.
So
It
Dr.
can be
Anil
silver
Agrawal is
nitrate.
asking, should we go for any flap thing?
Oh yes, one can definitely go ahead and do a flap, but in a case where a lot of manipulation of bone has occurred, I think the best procedure would be to do a flap. First, delay the flap, see if the circulation of that particular flap is good or not. And then in the second stage, you can debride and then cover it with a flap. We can definitely do a flap. Yes. A fasciocutaneous flap would be fine.
Right. Yeah, Gaurav, go ahead and show the final outcome.
Yeah, so this is an X-ray at around 1 year post-surgery.
Yeah, this looks pretty fine. And as I mentioned, this your telescoping rod is not telescoping.
Yeah,
It has disengaged from the distal end, and that is expected when it is jamming the canal. But still, Dr. Crawford mentioned that he used to protect all his CPT patients till skeletal maturity with an above knee brace, with a hinge knee brace. So I have still, you have seen already, we have been, although they are united, we protect them with an above knee. We don't want any further fracture here.
yeah.
So I think there's a good outcome.
I advised the same to the family, but then,
Oh, bapre.
sorry,
They dance kari yaar.
she's not listening. The family does not come to us now. But then I advised them to use a brace. I got one for them, but then they don't make her wear this.
Gaurav, if I can add something here,
Hello?
can I?
Yes.
Gaurav, I think to begin with, I don't know whether you have taken a straight incision or what. I would advise you to take a curvilinear incision.
Okay.
So that would also reduce the necrosis.
Right.
The contractile forces are different and they are broken down when you take a curvilinear incision rather than a straight incision over the shin of tibia.
Right, sir. I agree with you.
Yeah.
Fine. That's a good piece of advice. We have seen Dr. Raibakar using this curvilinear incision, which heals very well. And it also prevents this hypertrophic scar formation in the area of extreme mobility.
Yeah.
Yes, Shalin, please share your screen and let's go for first the foot pain case. Thanks, Gaurav. Nice presentation. And please ask them to put a brace on, it
Right,
should not
sir.
fracture again.
Yes, sir.
What is the range of motion at ankle and knee joint? That's what Anil Agrawal is asking.
Knee has got full range. Ankle is slightly stiff because of that K-wire from the fibula. I've asked them to get it removed. So they are not very compliant.
No, don't remove. No, if it is not disturbing, keep it there.
Okay.
Let it work as an internal splint.
Yeah, you definitely don't want to remove your K-wire unless you absolutely have to. And if you remove it, you probably want to revise it and put another one further up. Yeah.
Yeah, I
So
agree.
if I can make a quick little comment, I think,
Yes.
Dr. Eibacher, I think those are great points. I think that was very useful for us non-plastic surgeons. One of the other things to think about is, as we know, CPT is a long story. This is just the beginning of that story, and there will be many more chapters to come. And when you do need to go back in to do stuff again, one of the options at that point might be to get one of your plastic surgeons to come in and excise the scar and do a flap at that point. That might be a little bit more durable skin cover, because it is highly likely that at some point somebody's going to have to go back in for something, whether they refracture or whatever, right? So that is something that you can keep in your back pocket for now as an option.
Right.
True.
Fine. Let's start with another case, which is also pretty interesting. And maybe next month's tricky case, we have done one more abdominal flap. So that was also an interesting case we did with Dr. Aibakar sir. Yeah, Shalin, go ahead.
Yes, good morning, everyone. So it's an unusual cause of foot pain. An adolescent female presented us with right-sided foot pain since the past 1 year. She had abnormal walking pattern, and on and off the pain was there since 1 year, not resolving with local analgesics taken over the counter. So on examination, the pain was located over the plantar side of the foot. On examination, there was mild calf atrophy, and the child walked on the lateral border, skipping the medial side of the foot for weight bearing. There was no previous history of trauma, and the pain was aggravated by activities and weight bearing. So this was the presentation in the child.
Right. So, so Shalin, this should come as an animated slide. Okay. Do not. Anyways. So yes, Mihir, what can be the differential diagnosis of a unilateral foot pain in this 11 years old girl we should think about? Or
Sorry, I think I cut out at the very beginning of the history. So how long has she had the pain for?
She has a pain for 1 year.
Okay.
On one side, more aggravated on weight bearing. She is about 11 years old girl. And
No
she has a bit of
trauma.
calf atrophy. No trauma.
No trauma, no systemic symptoms, no fevers, no nothing, no night pain, none of that stuff.
No.
Okay, so well, the differential is actually quite broad, right? You can have, obviously, there's no obvious trauma, so that's one thing. Trauma is always something that kids will potentially be doing something that they won't tell the parents, and that's always something to keep in mind. Atypical infection is always something to keep in mind. But in this situation, it looks like she is basically walking with an antalgic gait and has decreased stance phase on that side to try and protect that leg. Now, I didn't quite see whether she was walking on the lateral border or whether she was walking on the medial border.
So this
it looked like she was more everted there and walking on the medial border, not so much the lateral border of the foot. Is that correct?
Yeah. I think so.
Okay.
She is daughter of my cousin brother. So she is kind of keeping the lateral border off while walking. And her mom was, and Dr. Anil Agrawal is asking whether any dancing, she likes to sit and eat and not very active child. And so there's no aggressive sporting or dancing activities, that is for sure. A very, very good child, Chinmay. There is no much thickening, Chinmay. Plantar skin is soft. I mean, there is no change in the consistency. So yes, Shalin, please go ahead with what we thought in differentials.
So for
what's the subtalar motion?
Subtalar motion was fine. There's normal subtalar motion.
So the joints were fine on examination. There were no systemic complaints. There were no diurnal variation of the pain. So with this, we thought of this diagnosis for a plantar-sided foot pain. but the calcaneal apophysitis could be ruled out because of the location of the pain, which was slightly distal over the metatarsals. Osteochondrosis was one of the consideration. Morton's neuroma was also one of the consideration. On some literature review, we found that children do have some pain, sometimes painful warts, but that would be visible on careful examination. Plantar fasciitis associated with enthesitis with idiopathic arthritis or juvenile rheumatoid arthritis is also mentioned as one of the causes of plantar-sided foot pain in children. Or some local tumors or infection would be other differentials.
Taral rightly said that can it be a stress fracture? Yes, we have seen a few patients with unilateral stress fracture, and we have got this metabolic workup done and local x-rays were done, and that will tell you the story. Yeah, Shalin, go ahead.
Yeah, so next on we went for the workup. X-rays of the local region were normal. Vitamin D, another metabolic workup was also carried out, and all of these were normal. And so we initially tried to manage with anti-inflammatories and avoidance of painful activities. And we called the child back after 15 days, but there was no improvement, no significant improvement after this initial treatment.
So one observation from Taral is the child also has a bit of genu valgum. Yes, Taral, I got a scanogram. I agree with you. But mechanical axis is passing through zone 1. So she has probably, we see a lot of kids with having a lot of thigh fat, and to accommodate that, they have a knock knee or genu valgum posture, but mechanically she is well balanced. So we got that scanogram done also. Yeah, so X-ray was normal and this workup normal. Mihir, what we should do further to confirm the, to come to the diagnosis?
So all inflammatory markers are okay. There's no family history of any rheumatoid arthritis, lupus, inflammatory bowel disease, any of that stuff, right?
Yes.
Because again, you know, if you have somebody who's walking with a plantar valgus, sticking her lateral border up, so there's some degree of potentially some perineal spasm, maybe even. So that's something else to think about. But certainly if labs are okay and the pain is persistent, then the next step would probably in our situation be getting an MR.
So that's what we also thought. Dr. Taral also suggested. Yeah, Shalin, show us.
Yes, so we got an MRI of the local region of the foot, and this are the images.
I would invite Dr. Sonali Desai. She is an expert musculoskeletal radiologist. Dr. Sonali, are you there?
Can you hear me?
Yes, yes, we can.
Yes, yes.
So would you throw a light on these images? And
yes. These are all fat suppressed PD images, and what we can see here is where the arrow mark is some sort of soft tissue edema, which is going into the third intertarsal space, and adjacent bone is looking normal, and there is no discreteness of the lesion. It is just ill-defined hyperintensities, and we have also done T1 and T2 images in this just to rule out any other fatty tissue or calcified tissue which was not there. Adjacent bone marrow is absolutely normal, and actually I have the previous scans also for this child. So 1 year interval scan, what I could find is the soft tissue changes are almost the static, but the marrow changes, there were some reactive marrow changes in the bone, which were not seen on the radiographs, and they are just a little bit of marrow edema kind of thing. So imaging differentials were like the same thing. If I would have seen in an adult, then I would have thought of a Morton neuroma. Now, because the child is in pediatric group, I would also put a differential of some other mesenchymal lesion, deep-seated fibromatosis also. Because when the fibrous or mesenchymal lesion in the inflammatory stage, we will not be able to differentiate what sort of origin it is, because everything will look bright on fat suppressed image. So imaging differential would be of some deep-seated fibromatosis or some Morton's neuroma kind of thing. Stress fracture and other differentials we did not think, because those changes were later on, and the predominant lesion is of soft tissue origin.
Do you have further images, Shalin, on this?
Yes, sir.
Or some closure images? Yeah.
Yeah, this also is showing this. See, the next one.
Go to the next one.
Yeah. Here we can see the marrow changes in the base of the third metatarsal. Yeah, this is the one. Yes.
So that can be the reaction of this
Reactive changes.
lesion.
Yes.
And this is going through the intermetatarsal space between third and fourth.
Fourth, yes.
What is this black? Is there any evidence of this being an venous
malformation? No. No slow
AV
flow,
malformation.
No, sir. It is not a vascular stop.
Okay.
Because the first scan which was done outside, which I had seen 6 months apart, that was showing just homogeneous hyperintensity on fat suppressed images, no adjacent vascularity, or no something kind of slow flow vascular malformation. It was not looking like that.
Yeah. So this this figure shows very there's something lying on the plantar surface of third metatarsal base, which is going between third and fourth metatarsal, but it can be the neuroma, fibroma, or something, So Mihir, what would you do now?
So I just want to say something. As far as Morton's neuromas go, number one, they're highly uncommon. Can you hear me now?
Yeah.
Sorry. So number one is I don't think they're very common in children. That's the first thing. Second thing is this is way too proximal to be a Morton's neuroma, right? Because your Morton's neuroma is between the metatarsal neck. This is way proximal. This is more kind of at the metatarsal base. So I would certainly not think in terms of a Morton neuroma just based on location itself. And then, as was pointed out, the imaging characteristics are very different rather than something that would suggest a neuroma. It's also a little bit of an atypical site for fibromatosis. Because fibromatosis, especially plantar fibromatosis, is going to be more superficial, more attached to the plantar fascia. This is right up against bone, so deeper than the muscle layer. So that, again, makes it a little bit less likely. Did we get any gradient echo sequences on this one? Did we see any kind of hemosiderin or any of that on these?
Yes, sir, we have gotten it done. There is no hemosiderin depositions.
Okay, because one of the things that can happen, it's not very common, but you can get something like PVNS, which is possible in the midfoot as well. So that's certainly something to consider as well, given its periarticular location.
Sir, so deep fibromatosis can also present like this in pediatric patient, not superficial one.
Right. So now, Mihir,
I'm losing you for some reason. My connection is not great today.
No issues. So Mihir, what would you consider now? Would you consider a biopsy or a needle biopsy, open biopsy, or what would you do? Or something non-surgical?
So I heard that we had some interval images, right? So you have 2 MRIs, how many months apart?
One year apart.
And how much of a change has there been over that 1 year?
The soft tissue swelling is same. The child developed a bit of marrow edema and calcaneum on the medial side, which is because she is avoiding weight bearing through the center. So that's probably my assumption is. But the soft tissue is the same. It has not changed. And the pain has also not changed. Pain is the same.
So she's been walking around on the medial side of the foot for a year at this point.
Yeah, and it's not like a shooting pain. When you tap, it will not shoot to the toe. like we see in some neuromas.
Sure.
It was not like that.
Yeah. So at this point, I think, since we have persistent symptoms, it will be reasonable to biopsy it, depending on how comfortable you and your radiologist and your pathologist are. You can certainly do that with a small core. Otherwise, you'll have to go open, which means you have to go digging into the middle of the foot, which is not an easy place to get to.
Right. So we, with the help of our orthopedic onco colleague, we planned a CT guided biopsy. So the problem was, even on the CT scan, we were not able to localize this lesion well, or we just went through the bony landmarks, and we thought that we have got the tissue, So Shalin, show what it brought.
Yeah, so we planned for a biopsy and we performed a CT guided biopsy by locating the lesion from the intermetatarsal space, which we planned using the MRI cuts, and based on the CT imaging, we could get a biopsy from the lesion. So the primary biopsy we sent for histopathological examination as well as culture. The culture turned out negative, and histopathological examination showed inconclusive fibrous and hemangiomatous tissue. It was not very conclusive for the diagnosis from the primary biopsy, the CT guided biopsy.
So what happened, that after this biopsy, the biopsy tract was inflamed, remained inflamed for 4 to 6 weeks. Right? And so we were waiting that earlier on she had some resolution of symptoms, but later on, after 3-4 months, again she came, no, the pain is the same and her gait pattern has not improved. And then she required some analgesics on regular basis. So then we came to a conclusion that now we have to go in, because even after doing the needle biopsy, we were not sure whether it was a fibrous lesion or hemangioma or AV malformation or a neuroma. So we were not sure whether to give some steroid injection or using sclerosant, so we thought that let's go for an open excision. And that's what we do. We waited for further 5 months, but her symptoms were persistent. So Mir, is the right approach to go for an open procedure at this point?
I think you're stuck, right? I mean, you've done everything that you possibly could with the needle and everything else. So now with persistent pain and symptoms, then you have to escalate. So.
So Taral mentioned meanwhile that MRI guided needle biopsy can be done. So agree, Taral, either a CT or some contrast imaging or an MRI guided biopsy could have been. Dr. Sonali, do you do this MRI guided biopsy?
No, we don't have that. In our setup. We don't have MRI guided biopsy. Specific titanium needles are required. Those things we don't have actually.
So I think for this soft tissue tumors, where it is difficult to locate through CT scan, we can have an MRI guided, and we can have that needle also if required. Yeah, Shalin, so move ahead and show what we did.
Yeah, so we went ahead and performed an open biopsy through the plantar approach. We went ahead and located the lesion. It was red in color, and we extended it, excised it, and we could see the metatarsal base where up to which the lesion was extending. And we could we could remove the tissue, entire tissue and block.
So I took help of Dr. Raibaker, and they are a bit more versed with this area, but he was of opinion that let us not go through plantar surface, let's go through the dorsal approach, take out a piece of metatarsal and see the lesion, remove it and put that piece back. And my opinion was let's go from the plantar surface because it's pretty lying right there. We might have to go through the fascia and all, but ultimately we went through the plantar approach, and with his loops, we could visualize an abnormal looking tissue. Still, we were not sure what it was, but we retrieved the pathologic tissue. Mandeep, my onco colleague, said that sometimes you go in and you find everything same. So you just have to assume. So intraoperatively, we use IITV to locate it, and we remove whatever it is. So show what came in pathology.
So this was the histopathological. These are the histopathological slides of the tissue we could obtain. And
Sanjeev, are you with us?
Yeah.
Yes, please, suggest us what it is and what do you think it is.
So we got a tissue which was we able to process in the one block. Not lot of tissue was there, and a different area was showing a vessels of different caliber. If you see left hand side lower, it was a very thin wall blood vessels, and some is containing RBCs. So these are the cavernous type blood vessels. In the right side lower, if you see there is a medium caliber blood vessels with the few muscle bundle. So these are venous caliber blood vessel adjacent to the arterial caliber blood vessels. If you see left hand side up, this vessels has a different type of tissue in the wall. Uppermost part is smooth muscle, whereas lower part is replaced by fibromyxoid tissue. So this is some sort of malformation, benign vascular lesion with some sort of malformation with abnormality in its vessel wall. So it's probably arteriovenous hemangioma or arteriovenous malformation, we can label it.
Yeah,
There was no other spindle cell component to comment whether it's a fibromatosis or any neuroma. No neural component was there. Even no evidence of PVNS, which Dr. Mihir was thinking about. So it's some sort of arteriovenous malformation hemangioma.
Yeah, so still that young lady is in plaster waiting for suture removal. Maybe in next couple of months, we will come and tell you whether her pain is gone off or not. We are not sure.
So
would it have been picked up on contrast MRI, Dr. Sonali? That's a question from Dr. Taral.
Sir, even if we would have done contrast imaging, see, as such, slow flow vascular malformation, some sort of vessel should be thin. When the vessels are very micro, we will not be able to see. Homogeneous enhancement would come in any of the mesenchymal lesion. So even after doing contrast, or even after doing arteriovenous contrast, dynamic contrast also, we would have not been able to differentiate.
Right.
Yeah,
Right.
Dr. Mandeep, sorry, Dr. Mohan. Last 1 year, we have 2-3 cases with Dr. Mandeep, which similar sort of age patient presenting with the bone pain, non-specific finding on radiology and biopsy showed nearly similar lesion with some sort of abnormal blood vessels and mildly cellular fibrous tissue, which was a cause for the recurrent continuous bone pain. So if it is very small vascular lesion, it's difficult to pick up on radiology.
Yeah, I know. Fine. So that was a learning case. Shalin, share the second case now. So the learning point from this case was that this is one of the differential of the foot pain in the child. X-rays would normal. I have very closely followed this family. They're very near relative, and they are quite disabled. So we have to keep these differentials in mind. Let's discuss the other. Okay, you want to discuss this? Okay.
Yeah. So an unstable reduction of a traumatic hip dislocation. A 6-year-old female was involved in a high velocity trauma. She was playing and suffered an injury due to a car accident, and she was involved in a road traffic accident. And she went to the peripheral center for primary evaluation, and this was the primary X-ray of the child. It showed a posterior hip dislocation of the left side, and primary emergency treatment in form of urgent close reduction under general anesthesia was performed at the center. And this was the immediate post-operative X-ray.
So, Taral or Mihir, like the treating surgeon said that after reduction, when he adducted, the hip got redislocated, and so he applied a Petri kind of cast, and he sent me the WhatsApp images. This look okay, and I said the same thing. There is increased medial joint line. Charlene, can you show that?
Yes.
Yeah.
Yeah.
So
This doesn't look like concentric reduction, right?
no, I mean, this is very classic though, right? We know that when we have our pediatric hip dislocations, just like you see in adults with posterior wall fractures, in kids, it's going to be more of a chondrolabral injury. And if the reduction is not stable, and if you have that much of joint space widening, then it's probably the posterior labrum that's stuck inside the joint. So for all of these pediatric hip dislocations, just like for all adult hip dislocations, once you get your reduction, you get a post-reduction CT to look for intra-articular fragments and all of that. For the pediatric population, once you get these back in, you really want to get an MR because you won't really see much on a CT. So this is very classic, and this is something to be aware of and something to look out for every single time you reduce these things.
So even though you see a similar joint space, you should always get an MRI to make sure that the labrum is not in. That's what you mean, right, Mihir?
Yeah, especially if you have any asymmetry whatsoever. But usually if it's symmetric stable, then it's probably unlikely, but you can always have chondral injuries that you don't pick up. So it's better to get an MR, and it's usually the labrum.
Right. So we found that it is asymmetric, and we advised an MRI. So Charlene, show those images.
Yeah. So as Dr. Mihir sir said, MRI is a investigation of choice and not CT for post-reduction instability after posterior dislocation in children. As these papers have already mentioned that posterior wall fractures, because of their chondral nature, would show up on MRI and not on CT scans. So
Taral, you want to say something before we move to this imaging? Taral? Okay, so Dr. Sonali, here are the images.
Sir, can we have the axial images? Can we have more images? Because some features are better in the axial. Yeah. So what we see here is there is a lot of edema. Yes, the other one. A lot of edema, which we expect actually in the dislocated hip. Here, this is the fovea. This one is empty. This is the opposite side for the comparison. So what we see is the ligamentum teres, which is minimus here. There's a high-grade tear, and the retracted fibers are located here at the posterior and inferior aspect. And the coronal, it is better seen on the posterior and inferior aspect. Labrum and cartilage is otherwise looking normal. So what we see here is a high-grade tear of ligamentum teres from the foveal attachment side.
The posterior labrum is looking okay, or it looks inverted? Or is it some tear at the posterior junction?
No, sir, there is crumpled up tissue there. So it is very difficult for me to differentiate. Because the ligamentum teres also retracted here, curled up with the posterior labrum tissue. So everything is.
So what I found on this, that compared to the opposite side where there is a pointing posterior wall,
yes, sir,
bone, and in the periphery there is a labrum. Here it is blunt, and there is discontinuity. So I thought that there should be also some labral injury. Along with these increase, there's something going wrong with the ligamentum teres, as you mentioned.
Yes, sir. Yes, sir.
So Mihir, your comment on these images?
You can see on that axial, go back. So on that axial, you can see your posterior labrum that is separated. That is the very tip. I don't think I can point on here.
Can you point that?
If you look at the very tip of the labrum,
Yeah.
At the back, yeah. And you see that dark part, that's the labrum. In between, you see a tear with all the bright signal.
Yeah.
And then you see what is more than likely capsulolabral complex, which is that black shadow that you see behind the head and between the head and the acetabulum. So that is quite typical of these injuries. Go back one slide. Shalin, can you go back one?
Yes.
So again, no, that one, yeah. So again, on this one, it's very nicely shown. If you look at the anterior labrum, see how nice and sharp that is? You don't quite see the posterior labrum in that same way. And you can actually see some of that capsule and that posterior labrum interposed right into the back there.
Yeah.
So that's what is interposed. That's what's causing the joint space to be wide. And that's what is making it more unstable.
Fine. So now how would you approach this, Mihir?
So it looks like it's mostly below the equator, right? So this is something that you can try doing a surgical hip dislocation approach. It's very hard to reach that far posteriorly with that. And, you know, can it be done? Yeah, I guess if you're Prasad, you could probably do anything through a surgical hip dislocation. But for me, we actually had a case like this recently that came to me probably about 5 or 6 weeks later. And everything was stuck inside. So I actually went in with a standard Coker Langenbeck. And that allowed us to really look at the capsule and the labrum and pull it out and then do a proper repair with suture anchors, which, you know, at least in my hands, through a surgical hip dislocation going that far posterior inferior is not possible.
Yeah. So we thought there are 3 approaches. Like we can go in front, but it would be difficult to reach to the posterior labrum through the front approach. Safe surgical dislocation, again, here we might have to modify the technique, not to do a GT osteotomy at this young age, but we may require the gluteal tenotomy. Or as it is already posteriorly dislocated, the posterior capsule would have been torn already. So you can go through posterior approach and see if you can dislocate and see the joint. So I inquired with Prasad, I sent all the images, and he said that you can go through the posterior approach, and then if it is required, you do gluteal tenotomy and convert it into a safe surgical dislocation approach if it is required. So Shalin, show how we approached it.
Yeah, so as Sir said, these were the issues regarding the approach, and we went ahead and because of the aforementioned reason, used a posterior approach. So we put the child in lateral position and used the standard KL approach. And these were the external rotators. And as seen here, there was interposed capsular tissue, and there was a rent in the capsule. Using it, we could get, on just a simple manipulation, we could easily dislocate the head. And there was torn ligamentum teres, the one seen in the MRI, and the ligamentum teres there was a high-grade tear, and the soft tissue of the ligamentum teres also was interposed between the joint, and it was crumbled up along with the interposed labrum. There was no significant labral tear, but it was interposed soft tissue which was hindering the reduction. So,
yeah. So it was difficult to visualize inside the joint, you know. So we just incise the capsule a little bit, put a hook across the neck, and gently positioned and pulled the head in front, and we could see the joint. Excise the ligamentum teres with a Metz scissors, and the labrum was relocated, and the hip was reduced, and it was checked through the range of motion. What we were worried about was avascular necrosis because of this high degree dislocation, but we could see that the head was bleeding well. So this child probably had preserved blood supply. So about 15 to 20% children can end up into AVN, but this child was fortunate. Probably the anterior capsule and the anterior vessels were intact. Yeah. So we gave her hip spica and repaired the capsule not very tight from behind, and we applied a hip spica for 3 weeks. So that's how we managed it. So Mihir, your comments on this. Now
Yeah,
it
and I
looks
think
okay. Yeah.
that looks great. I think that is the key, I think, is for residents, if we have residents on the call, the key is to recognize the fact that there is soft tissue interposition, most likely capsulolabral complex, that then is the cause of the widening of the joint space and instability. And that needs to be identified and that needs to be dealt with early, just like you did, rather than waiting the 5 weeks for the case that I did, which then made life even more challenging to try and get stuff out because everything was stuck. But identifying that, addressing that is key. You know, you will always, for a significant dislocation, you know you're going to have a ligamentum teres there. You cannot dislocate the hip without tearing the ligamentum unless you have significant ligamentous laxity. So expect that. That usually is not the biggest hindrance in that situation as far as reduction is concerned, because if you think about it, the ligamentum actually lives inside the joint. So it cannot necessarily be the cause of major interposition because it's always interposed to start with.
Yeah, it must be the labrum here.
Yeah. One of the other little tricks is to use some traction. If you are finding it a little hard to visualize the inside, and that can oftentimes give you a little extra visualization. Sometimes you can actually even stick a small scope inside dry just to aid in visualization and also as a light source. You know, even if you can't see a whole lot, at least you get some light. We have an illuminated sucker tip that we use. So that really is very helpful in visualizing things there. But I think this will be fine. You've got it reduced nicely, and once it stabilizes and heals, it should be good.
Right. Fine. So let's quickly glance through the last and most interesting case, Shalin. Although we have finished the time, just switch to the last case where we want Mihir to comment. You're mute, Shalin.
Yeah, so this is the last case for the day, an unusual paraspinal or chest wall swelling in an infant. So an 11-month-old child, a girl presented to us with rapidly increasing paraspinal or posterior chest wall swelling over the past 4 months. So this was the initial size and gradually increased to the size which became almost the size of the scapula in the child for reference. And it was a rapidly increasing swelling in a child. It was present in the subcutaneous region. We could, it was not moving with movement of the muscles, and it was not bony. It was just it was soft to firm in consistency and moved within the subcutaneous tissue, free from the underlying muscle and the bone. So
yeah, so it was not a simple lipoma kind of feeling on clinical exam. So let's rush through the differentials we thought, and then we have to show what.
Yeah, so for the differentials of a chest wall swelling, this would be the differentials for benign tumors would be desmoid hematoma, hemangioma, or cystic hygroma, and for malignant tumors would be synovia, malignant mesenchyma, rhabdomyosarcoma, sometimes a tumor of the bone, but of the ribs. But this was not bony inconsistency. We got an X-ray. There were no calcifications or specific changes in the wall. We went ahead and did.
Just a moment, like an infection is always on back of our mind in India. So Mihir,
two things from a differential perspective. in infants, one of the things that you really want to think about is a lipoblastoma.
Right.
Okay. Especially around the shoulder in the first couple of years of life. That is a fairly common thing to see. And it can be partially soft, partially firm. So that's something to think about. The other things to think about from a rapidly growing soft tissue mass perspective, especially in an infant, is you talked about rhabdo, which is certainly the most common malignancy. But something else to really keep in mind also, and this doesn't quite look like it, would be an infantile fibrosarcoma. Okay. Those also can be rapidly growing. Some of them are actually seen at birth, and they will grow rapidly. They're very vascular, so oftentimes they may mimic a vascular malformation as well. So keep those things in mind in addition to some of the more exotic things with your differentials.
So the MRI was advised. Shalim, please show
Yes.
that images. Glance through the images, and then we'll ask Dr. Sonali to comment on it. Yeah. So, Dr. Sonali, what do you think it is?
Sir, what we can see is the large tumor, heterogeneous tumor showing lipomatous component. Can you show me the next slide, please? One more, I think T1 images are there. Yes, this T1 images is showing the lot of fatty tissue within the lesion. The lesion is between the trapezius muscle and chest wall muscles. More of the lesion is in the intermuscular plane, reasonably well defined. And the other soft tissue is looking like that of the muscle and fibrous tissue. T2 images, can you show the next one, please? Yeah, T2 images, it is showing quite a lot of fibrous and muscular signal intensity areas within. So reasonably well-defined intermuscular plane lesion in a child with internal fatty and soft tissue components. We would think of lipoblastoma, fibrous hematoma, involuting hemangioma, and some sort of teratoma maybe. This 4 would be the differentials. There is compression on the muscle. As such, there is no muscle edema. So aggressiveness is not looking. It is not very aggressive looking lesion as on MR.
Right. So the duration was also like parents observed this for the first time at 3 months. And this size has increased over last 7 months. So although it doesn't look like extremely aggressive, but still it is not like lipoma or something which
no,
would
it won't be simple lipoma. It would be lipomatous lesion.
So this is a benign but aggressive looking lesion.
Yes, like we're having lipomatous components.
Yeah. And so we went ahead with the biopsy. Yeah, Mihir?
Shalin, I will tell you that your physical exam of it not moving or it moving separately from the muscles is very suspect, dude. That's misleading there. All right. So what did you find in the biopsy?
Now, what I say, it was not like a lipomatous exam, you know, it was not moving. It was kind of bit firm.
Yeah, no, it's stuck to the muscle there.
Yeah, it is stuck
it's in the muscle. So you cannot move it separately. It's not a subcutaneous mass that's moving separately from the underlying muscle as was presented. So that moves you in a slightly different direction as far as differentials go. But go ahead, tell us what you found.
Yes, so we went ahead and performed a biopsy of the lesion, and biopsy showed primary, it was pointing towards neurofibroma. However, the clinical exam did not show any other body spots, and the lesion was rapidly and locally aggressive. However, there were no infiltrations of the muscle in the MRI. We went ahead and planned for a excision of the lesion.
So Mandeep is here. Mandeep, are you with us?
Yes, Maulin.
Yeah.
Can you see me?
Yeah. So yes, after biopsy, it was reported neurofibroma by Sanjeev. So we planned with an excision. So we had a big meeting with the family because their expectations about the resumption of movement and all. So we had a couple of sessions with the family that this is incorporating probably the rhomboids and trapezius, and it is aggressive. We have to take it out, and it may leave behind some limitation of range of motion. So it took a few meetings to bring the family to the realistic expectations. And as far as the surgical thing is concerned, Mandeep,
Yes, Maulin.
yeah, please share what were your plans about this?
Can
No,
I
so this is,
quickly say one thing?
Yes.
I would very strongly suspect that this is not a neurofibroma. The imaging is not consistent at all with a neurofibroma. No neurofibroma is going to have fat within it.
Yeah. So we will
So-
come to that point,
Yeah.
and why this needle biopsy diagnosis is different than the final, and the Sanjeev
Sanjeev
will
around?
explain to that.
Is Sanjeev around?
Yeah,
Yeah,
Sanjeev
yeah.
is here. Yeah.
Yeah.
Sanjeev, why don't you tell us what was going in your mind? Why did you call it a neurofibroma in the first place?
See, this biopsy was showing mildly cellular, bland, benign-looking spindle cell and adipocytic component. So my differential was, this is a diffuse neurofibroma. In diffuse neurofibroma, the spindle cell can infiltrate adipocytic component or normal fat tissue. There was a skeletal muscle which was showing infiltration in the biopsy. So it was infiltrative tumor or lesion. Diffuse neurofibroma can have, apart from neural component, as a part of it, other mesenchymal component also, like blood vessels and adipose tissue. So I was sure this is a benign but locally infiltrative tumor, bland spindle cells, so most likely neurofibromatous tumor, but no evidence of malignancy was there. Now our concern was the surgical excision. So we decided actually that final diagnosis will put on resection. At present, it's a benign but locally aggressive tumor, probably neurofibroma.
Yeah, so maybe even we had this doubt in my mind that probably we will have a different diagnosis at the end of the resection, because as you said, the radiology was not classical for a neurofibroma, but for us it was enough to for us to decide that we have to go in that it's a benign lesion and it's an aggressive lesion. It's not something like a benign indolent lesion which can be put under watchful observation. So it was very clear from the biopsy and from the clinical history and examination, because this tumor was growing at a pretty fast pace. And now the pathology showed that it is a benign and aggressive lesion. It's not an indolent lesion. So it was enough for us to go in and take it out. We explained this to the patient that we might have a different diagnosis at the end of the resection, but this is not malignant, and we were all on the same page as far as that was concerned, that this is not malignant, because imaging was not malignant, and even pathology was not malignant, and it was at the same time not indolent also. So we had to go in and do a surgery. So we planned to
Mandeep, I completely agree. I think that, when this is something that, just like you tell your residents, I tell my residents all the time as well, is if things don't add up, which means your clinical picture does not match with your imaging picture, or it does not match with your pathology picture, then you have to dig deeper, which means you have to get more tissue, in this case, doing an excision or whatever else, because something doesn't add up. So you definitely need to have more definitive data. Yeah, absolutely.
As we call it, a jigsaw puzzle, that everything has to match and make it a picture. So that's fine. But here, doing a repeat biopsy didn't make sense to us, because we were very sure that this is not malignant. And we were also very sure that we are not going to observe this lesion. We are going to take it out. So we decided to go in and do a wide excision, with negative margin excision. That is what was the plan. And that is what we executed.
Yeah, Shalin, show those images. Go ahead.
Yeah, so we went ahead and did a wide local excision of the tumor.
So Mandeep, you want to explain?
No, I think
it's self-explanatory pictures.
And basically we aimed at not a really radical margins like in sarcomas, but maybe a marginal to little wide margins. Basically what we usually do for a benign aggressive lesions.
Yeah. 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 So,
Again, quickly before we jump ahead, if you're thinking that this is a neurofibroma, something of that size would be something like a plexiform, right? It won't be a regular old neurofibroma that would look like this and that would grow that rapidly. So number one, even plexiform neurofibromas at that age will not grow that rapidly. So that is also something that doesn't quite add up. Then when you look at this grossly, this is obviously with a margin, but it doesn't have that typical infiltrative growth pattern on the MR or on your clinical specimen that would then suggest that this is a plexiform either. So curious to see what your final path was.
move ahead with it. And Sanjeev,
See, grossly, the tumor was whitish in some layer yellowish. It had consisted main component was adipocytic and this benign fibrous appearing spindle cells. In about 7 to 10% area, there was a myxoid nodule, third component, which was not there in biopsy. Even on resection, it was very small, 8 to 7 to 10% component was myxoid appearing nodule with primitive appearing cells. There are some more images of this myxoid area with the bland oval to round cells. So and this adipocytic component, there was no lipoblast. So my diagnosis was fibrous hematoma of infancy.
I think that's perfect.
yeah, go ahead with other
That
image.
component, that myxoid component was not there on biopsy.
Sure.
And
No, that fits perfectly.
Closest differential diagnosis of this tumor is actually liponeurofibromatosis. That's the closest differential diagnosis on core biopsy. And there was no evidence of any malignancy on almost, I took 15 sections with margin, 10 from tumor.
Right.
Yeah, no, Sanjeev, I think that shows it beautifully there. You've got all the three components that you need for a fibrous hamartoma diagnosis. And that fits in nicely with the history, that fits in nicely with the imaging. So now this is a nice, well put together package that, you know, all of us can rest easy with and be happy about.
I think repeat biopsy may not have helped any more on doing repeat biopsy in this case.
Unless you had hit that myxoid component, which was very small, and unless you had actually, I mean, if we had this suspicion based on radiology that we have this myxoid component and we want to target that component under CT scan guidance or under any imaging guidance, and we could target that that particular area, then we could have hit this diagnosis before surgery. Otherwise, there was no other way we could have hit this diagnosis. This is actually a diagnosis of resection. May correct me if I'm wrong.
Yeah, no, I think that's very reasonable. You know, if you were able to pick it up on MR, then that would have been a completely different story.
Yeah.
But overall, I think that this makes sense. You were able to take it out without too much morbidity, which again is important in these situations. So all in all, I think very appropriately managed.
So for less educated people like me and my other fellows, Shalin, please take us through the literature briefly.
Yes. Yeah, so fibrous hematoma of infancy, as Sanjeev sir told, its majority of these cases occur within the first year of life, and about 25% of them are congenital. Axilla, upper arm, trunk, external genital area are the common occurrences. Chest wall is also one of the few regions, a rarer area, but it can occur in those regions, has been mentioned in the literature. The lesion's histological appearance, as mentioned, has three classic different tissues: fibrous trabeculae, mature adipose tissue, and immature mesenchymal tissue. All of three which were classically shown in the histopathological images before. It's a locally aggressive lesion, and treatment of choice would be what we did in this case, as mentioned, wide local excision. So these are some literature which some papers which mention this and some of the pathology associated with it.
See, now because of this this EGFR exon 20 insertion duplication, this is not considered now as a hematoma. This is considered as a complex neoplasm, not hematoma.
And this has a pre-malignant potential. This is a
Two of cases had a sarcomatous component that was on the fish ETV6 negative. So that also exclude infantile fibrosarcoma.
Right. So this was again a bit tricky for us. The very rare situation with the help of a team. We are fortunate to have Mandeep, Sanjeev, Dr. Sonali went to help us reaching to the diagnosis and make right decision for the patient. So thank you very much, Mihir, for your time. And thanks
Absolutely.
everyone.
Thanks for having me.
Yeah. So we'll meet again next week with some other academic stuff. Thanks, Mandeep, for your input.
Bye.
Mandeep
Bye.
is, Mandeep, are you Secretary of INSOS now?
President.
No, so Mandeep is President of Indian Musculoskeletal Oncology Society now, Mihir.
That's
And
great.
he is
Congratulations.
hosting the annual INSOS meeting in Ahmedabad next year. Yeah, but
Excellent.
it's a virtual meeting, so yeah. So we have good.
So
help.
Mihir, we might send you an invitation to be a part of that meeting because so we are in the process of making the scientific program, and you might receive an